So I'm Megan Neubauer. I'm the Executive Director of the Michigan Ovarian Cancer Alliance. I'm so happy to be with you all tonight, so thank you. And we're happy to be in partnership with Apricity Health around this webinar tonight, so thanks so much for that. And we're so glad to have Erin Tardanico here with us tonight. Erin is an Oncology Certified Nurse and a nurse practitioner, and has previously worked at patients' bedside for over 15 years as an oncology nurse, and specializes in the medical management of gynecologic oncology patients. So we are thankful for you to come and share with us, and I will hand it over to you here so that you can walk us through these pieces and let me know if there are any questions throughout. We can make sure that those get answered.
Can you hear me? Okay, perfect. So thank you guys so much for inviting me here tonight. This is a first for me, but honestly, what we're going to talk about is stuff I talk to my patients about every day. My goal is just to kind of first give you guys a little bit of an overview of maybe some of the tips and tricks we start and we tell our new patients to kind of take some of the scariness out of the new patient journey. I don't want anyone to feel like they can't stop and ask questions, so please feel free to interrupt me. And I'll go into some of the broader descriptions of treatments for ovarian cancer. And then at the end, we'll go into the symptoms and the side effects from treatment and kind of how we manage those. So if anybody has any questions, please feel free just to jump in or use the chat function. So when I see my new patients, I always recommend that they just grab a little notebook and kind of keep it with them. There's questions that come up that you forget and you want to ask when you're there. Sometimes it's easy to get a hold of providers after your visits. Sometimes it's a little bit more challenging. So if you keep a notebook, after your treatment, you can kind of write a few notes after each day. You know, this went well, this didn't went well. That way you can kind of report back for your next visit and you can give your provider some feedback on how things went, and hopefully they can kind of tweak the recipe for you. Whatever treatment you're on, there's always adjustments that can be made. So that's really helpful for you, so you don't have to have the pressure of remembering, and for the provider, so that you can give kind of detailed descriptions on what went well and what didn't. Also, some of the treatments do cause complete hair loss, so we recommend that patients always ask for a prescription for a wig. Sometimes insurance companies will give you some money off towards that, and it's helpful at least to save, even if it's $100, because really there's so many fees that go into being a patient, from parking to food. There's just really so much. So we recommend that you call your insurance company first, find out how much they're going to reimburse you for before you start shopping, just so you know how much you might end up paying out of pocket in the end. The other thing is, I always recommend my patients to get a second opinion. Any great provider really should encourage you to do this, or at least give their blessing for it. We are so lucky to have so many great health centers near us. I'm in Massachusetts, but you guys also over in Michigan, you guys have a lot of great centers that nobody should feel like there's one option and they only hear from one provider. It's, you know, the beginning of your journey, and you should find a provider who's a good fit for you and somebody who you connect with. I think that's really important, and sometimes patients are a little afraid to do that, and I don't think you should be. This is your life and your body and, you know, your diagnosis, so really you should kind of figure out the best plan for yourself, and don't be embarrassed about it, or don't be shy. Just be forthcoming and don't let it slow down the treatment. That's a really important thing, is, you know, you can always get started somewhere with your treatment and get a second opinion while it's going, and that way if you needed to change, you could, but starting treatment right away is always really important. Also, we fortunately have a lot of patients who have really great support systems, and a lot of times patients get overwhelmed with how much support. They have friends and families reaching out, what can we do? And our patients really want to give them something to do so that they can feel helpful. And we found one of those easier ways to do that is just to, you know, kind of assign different friends or family or whoever wants to help different days for your treatment. So you have a ride and you don't have to worry about it. And it gives, you know, maybe your more permanent care person a little bit of a break, and they get to help. And it's nice to kind of continually get all the support you can. So basic chemotherapy, there's two medications that are kind of the backbone to ovarian cancer treatment, the tried and true carboplatin and paclitaxel. Probably you guys know there's national guidelines, NCCN guidelines. This is going to be the #1 recommendation from any provider that you see for ovarian cancer. The only time you might get something different is if you meet with providers and you're looking into clinical trial options. They're very high dose medications, and they're given once every 3 weeks for usually between 4 and 6 treatments, and that one treatment day is referred to as a cycle. There's also other chemotherapies I'm not going to go into, but if those medications don't work for you, they can sub one medicine out, and there's other medications that you can use in like second-line treatment, meaning if you finish treatment and you still have disease and they needed to give you more chemo, they could use other ones, and then in the recurrent setting. So if your cancer is cured and unfortunately it comes back, then there's other medicines they can use. Maintenance therapy. So a lot of our ovarian cancer patients are now eligible to have a maintenance therapy. So after they get their original kind of recipe of chemo, something that you can stay on for a length of time to kind of buy the insurance of knowing that you're doing something active for your cancer and to reduce your risk of it coming back. Or if you still have disease, you know, try to keep your disease under control. PARP inhibitors and bevacizumab are the two main medications that we use for this. PARP inhibitors are considered a targeted therapy. There's chemotherapy pills that are offered to lots of ovarian cancer patients. There are some specific patients who might have like an inability for their DNA to repair themselves, who are kind of the better candidates for PARP inhibitors, meaning that they get a lot more bang for their buck. They have a longer progression-free survival when we use them in that patient population, but it's also available for patients without those kind of deleterious mutations. Bevacizumab is another medication. It has a lot of side effects, so we'll talk about those a little bit, but the interesting thing about that medication is that how it works is it kind of stops the blood flow to the tumor and kind of starves the cancer, which is very helpful if you have kind of persistent disease. Immunotherapy, which I'm sure everybody is excited about, as all of our providers are. Dostarlimab and pembrolizumab are the two main ones that we're using. They're both IV infusions given once every couple of weeks. Certain patients are also kind of at a better chance of having a better response based on the certain, I should say, like specific testing that's done on their tumor. So there's something called tumor molecular analysis that your medical provider will request on your tumor to find out if you would be a better candidate for this kind of medication. So kind of fancy schmancy terms, but they call it MSI high, or mismatch repair deficient, or TMB is for tumor mutation burden being high, so over 10 mutations. So a lot of times the providers will send out this testing and then they'll get a report back, and maybe you'll get a copy, maybe it'll be scanned into your record somewhere, but you could kind of like look at all these things. But I think the kind of take home message is just to know that there's very specific treatments that are around that your tumors can be tested for, or a biopsy sample if that's what they have. So always feel free to ask about that for your providers. There's a brand new brand new drug that hit the market called Elahere, and we've been using it so far, but it's a drug that's in this antibody drug conjugate class, which there's like less than 20 medications in this category. It's a relatively newer drug class. I think it's like 20 years old or so. So this medication, again, you have to have a very specific test done on your tumor or the biopsy that they've used, and they do something called folate receptor testing, and they'll test your tumor to see if the staining for folate receptor is above a certain percentage, and if it is, then it means you're eligible for this drug. The kind of reason most of us with who are managing ovarian cancer patients are really excited about it is because we have mainline treatment, carbotaxol, which, you know, usually over 80% of people respond to. And then this is the next drug that has a really, really good response rate, being like for over 30% for the people who are positive for this folate receptor testing. A lot of the other medications that we have are a much lower chance of response. So when we get second line treatment that has really good numbers like that, we're very excited. Okay. So symptoms. I always tell my patients fatigue is the one symptom I can almost promise you. There's a lot of side effects. Nobody gets all of them, but nobody gets none of them either. Fatigue is absolutely the one everybody reports. So I try to teach my patients, I think a really good way to kind of try to handle that is to basically just cluster the things that you need to do. If you know you have a few things you need to do, make sure you're scheduling activity and then rest. You can't schedule a whole day of activities, and maybe that's what you're used to doing, but you have to be able to kind of calculate some rest time in there for your day, so that way you can conserve your energy. And also there's other reasons for, you know, fatigue aside from just chemo. So a lot of the providers will be looking at things like, are you anemic, or is your thyroid not working properly? So it's also an important side effect to report to your provider so that they can check for those things if they need to. Okay, we will talk about that a little bit at the end. I just saw the chat. And for some patients, our palliative care providers will even give them stimulant medications that are used in ADHD if needed, in very low doses to try to give people the energy that they need to be able to do the things that are most important for them. Nausea and vomiting. We have so many great anti-nausea medications that I tell my patients, if you're vomiting at home, you need to cut less because we need to do better. There's a lot of medicines that are offered, and different ones have different, I should say, like better uses. Some are better at preventing nausea. Some are better at treating nausea after it started. And then there's even some that are better for something called anticipatory nausea, meaning I've had patients kind of show up to clinic and they say as soon as they sit in the waiting room, they're already queasy. And it's because they've, you know, already connected being on this floor with nausea from their last chemo regimen or from a previous time. So there's different medicines have different kind of better ways to use them, I guess. And doing things like trying to eat smaller, frequent meals are really like a better way to avoid nausea. If you eat large meals, that can make things worse. And also avoiding very hot meals, because if they're, you know, think about it, if you're at a restaurant, when they're serving all these hot meals, there's so many odors wafting around, and sometimes just those smells can really turn people off from food. So if that's something, you can try to have food at room temperature, or even, you know, put your food in the fridge and eat it cold. Another thing that's been shown to help people eat more is to actually put a smaller volume on your plate. If you overwhelm your plate, you are overwhelming your brain, and you will eat less by default because it's already intimidating. So if you try to, you know, put half of your portion on your plate, see what you can eat, and you can always add more, but I'd rather you have less on your plate and successfully eat it than put a lot on your plate and only have 2 bites and be turned off. Constipation and diarrhea, both very, very common with a lot of our patients. If it's chemotherapy related, sometimes the doctors or providers can give you medications to control it. Sometimes our patients find out maybe if they're having like a targeted radiation, and you know they can't have salads anymore. Salads are just not helpful. So kind of figuring out what the trigger is. So again, if you have a little notebook and you're writing down, you know, I ate, I don't know, I ate like blueberries and dates, and then you have diarrhea, then you know that maybe isn't the best idea for next time. and trying to stick with some more bland foods like toast and rice, things that'll bulk your stool up and hopefully protect you from having as much diarrhea. For appetite and taste changes, a lot of times our patients come in and they're saying that they don't have an appetite, and really they have kind of low-grade nausea, and they're not really recognizing it as that, or kind of this, you know, they say, oh, my stomach just doesn't feel right. And sometimes it's more helpful to take a nausea pill half an hour before you eat, so that way you can kind of maximize how much food you want or how much food you'll be able to take in. And some of the patients also have changes in their taste just because of the medication. So our platinum drugs like carboplatin, the one I mentioned, a lot of times people just can taste metal. So they'll, you know, I recommend don't use silverware, kind of a simple thing, but if you're tasting metal and you put a metal spoon on your tongue, you're gonna taste that metal more. So using things like plasticware, bamboo-ware, which now they sell everywhere as well, can be really, really helpful. And also just avoiding foods from metal objects like canned vegetables, cooking in a metal pan. Now they have ceramic pans. You know, there's ways to kind of avoid any metal touching your food to try to keep the taste as natural as possible and less metallic. Neuropathy. Lots of our medicines cause this. So I personally have a lot of patients that we treat the neuropathy. Obviously, when neuropathy does happen, kind of trying to manage the medications and minimize the amount of neuropathy you have is always the goal. But if you're stuck with it and you're dealing with it at home, there are lots of medicines that can help with these. A lot of times people are prescribed anticonvulsants and antidepressants. And if they don't have an effect, they give up. But a lot of these medicines can be titrated pretty aggressively, and people can have really great responses, and they can even pair them with other meds to help them work better. Palliative care providers are really, really great at managing that too. So if you're having any symptoms and you feel like your primary team hasn't been able to manage them as well as you would hoped, trying to ask for a palliative care consult could always be helpful, because they're just there for symptom management. You do not have to, some patients say, but I'm not dying, and you don't have to be dying to go see PalCare. PalCare is there just to help you with any symptoms that are bothering you and lowering your quality of life in any way. So don't be afraid of that team. They're really, really absolutely important and priceless to our team. Pain and discomfort. So heat, cold therapy, very easy to do, having, you know, those little hot packs that you microwave in the microwave, or, you know, using ice in a little bag or something can be really helpful. Some patients use things like, I'm blanking out on the name, copaiba oil that can be mixed in a diluent like olive oil and applied as like a topical massage. And then there's obviously lots of prescription medications for pain. That's just something that is like a very, very broad topic. So I think making sure you know the cause of your pain before you're treating it, always reaching out to your provider and making sure that whatever pain you have is, you know, an expected pain from your cancer, and it's not something else that's happening and that's a problem. But there's lots of different ways to manage it, with pills, topicals, injections, you name it. Menopause. So obviously, if you have ovarian cancer, you've most likely had all of your ovaries removed and you are put into instant menopause, which is very challenging. Absolutely challenging. You know, natural menopause takes over, you know, 10, 15, sometimes 20 years, but to have that surgically done is really, really difficult. And unfortunately, a lot of, in our practice, we rely on our oncology surgical team to make the decision on whether hormonal therapy is an option for the patient. But as you probably know, that can be contraindicated since hormones can drive certain cancers. So we always defer to our surgery team for that, but there is a use for them. So you have to kind of figure out from your team if you're a good candidate for it or not. But as far as non-hormonal options, there are also a lot of those. There's they use a lot of SSRIs and also anticonvulsants, a lot of the same drugs we use to treat neuropathy. That can be really helpful with all of the like temperature regulation issues as far as menopause goes. And for vaginal dryness, we usually tell people, start simple, use coconut oil. A lot of my patients have done this and found it very helpful, but I tell them in the supermarket, they have these little ice cube trays and they're little teeny tiny ice cube shaped. Usually they're like smooth and rounded on the bottom. But if you buy like a clean bottle of coconut oil and you put coconut oil in all of these little things and then put it in the fridge just so they solidify, then you can use those as intravaginal inserts for the dryness. So it can be a little messy. Recommend, putting it in at night, wearing a panty liner to bed, but that can really help with the vaginal dryness, even inside and more towards the intraitus. So, and it's naturally antifungal. So if that doesn't work, or you for some reason can't use that, or it's too messy and you don't like it, there's multiple over-the-counter products that are vaginal lubricants and moisturizers. Some of our favorites are Good Clean Love and Replens. Those are the two that I've had patients have the best experience with. And I think that's it as far as this. I'll let Sam do this and then I'll kind of jump into questions.
Thank you, Erin. Yeah, so let me start by saying thank you, Megan, and the MIOCA group for partnering with us, letting us partner with you. Thank you, Erin. That was a great talk. A lot of insightful stuff from, daily, seeing patients daily. Again, my name is Sam Wang, and I'm a physician by training, but for the last 3 years now, I've been working as the Chief Medical Information Officer at Apricity Health. And our primary goal, as we've been developing ApricityCare, this service, is to help cancer patients manage symptoms, right? Their side effects from cancer treatment. So, there's been plenty of studies that have shown if you can manage these side effects, all these things that Erin's been talking about, if you can head them off at the pass, if you can take charge of all these issues early, your cancer treatment will less likely to be interrupted, right? We want absolutely for you to go through your cancer treatment and have as good a chance of, wiping that out as possible. So we've been working pretty hard at Apricity Health here to figure out a way to manage and help you manage your symptoms at home. So we built a system where we have 24/7 care at your fingertips with a nurse at the other end of it. So if you have any symptoms, you punch it into our app. And if the symptoms are bad enough, one of our nurses will contact you. Even if they're not bad, a nurse can contact you if you'd like. So the whole point of this talk essentially was to sort of give everybody a little bit more insight into all the side effects, all the symptoms, but not just to sort of make you aware of them, but also figure out a way to manage them. So we've been partnering with MIOCA to have this open beta, and I stuck the registration code over there. It's called MIOCA Beta. If you go to the App Store or the Google Play Store, you'll be able to find our app called ApricityCare and just register yourself. And when you get to the registration code, punch that in and it'll tie you to the MIOCA program. And sorry, that's my pitch, but we really kind of wanted to get this out there. And so we thought this webinar with MIOCA would be the best way to do it. One other side thing that we've been trying to figure out is whether there's a need for these clinical trials services. Everyone that's going through and fighting the cancer may not necessarily, cisplatin is never going to be the silver bullet. And so there's a bunch of clinical trials out there. They're hard to find though. So the question is, is there an interest from, the patient population to get a system that can alert you if you match into a clinical trial, or if you are, I should say, not match, but if you have a better likelihood of joining a clinical trial. So we're trying to build this service, and we're trying to see if there's interest to it, towards the service. So we stuck my email here at the bottom there. You know, feel free to email me if you have any questions or if you're interested in it. And you can even, if you're in the ApricityCare app, you could send us feedback about this clinical trial if you are interested in it.